I'm Manjit Gohel. I am a vascular surgeon in Cambridge in the UK. It's a pleasure to welcome our speaker for today, which is going to be Alejandro González from Mexico. And we also have some guest discussants. So we're going to have Dr. Malay Patel from India and also Dr. Liza Ochoa as well. So we're going to have a good discussion.
Thank you for the invitation. Always nice to speak among friends. So this is a slightly controversial topic. It raised a lot of rounds, but so now, to be fair, I'm a consultant for venoactive medications for severe and alpha sigma, but I'm not getting paid, so unfortunately. Now, we're going to be talking about cardiovascular disease and chronic venous diseases. There are risk factors there. Now, chronic venous disease has been said there is a risk factor, but is this the risk factor or is this the same risk factor? So is the severity important in this space? Now, a little background because it's going to play out when we talk about medications. We have the endothelial cell that we know is not only the Teflon for the vascular layer. It is a multifunctional organ that has a lot to do with hemostasis and different aspects that regulate our normal function as a body. And it has a very important part that is called the glycocalyx. Now, the glycocalyx has different settings in different organs, but it's a very important part that regulates the proper function of the endothelial. Now, this glycocalyx is very susceptible to injury, to change. And this is where the relationship between chronic venous disease and cardiovascular risk starts to make a little sense because they share a lot of risk factors. Age is as simple as that. As we get older, this glycocalyx starts to affect and we start to lose some integrity of this glycocalyx. The studies show that in rats, when they compare young and older, you can see the difference in the thickness of the glycocalyx and the spread of the glycocalyx. This is important because as the glycocalyx, due to injury or age or whatever, starts to disappear, it produces these patches of these little holes in the endothelium. And this process that looks like this, that several anchor and receptors change their function. And this promotes liberation of certain biomarkers for inflammation that can increase the possibility that those lymphocyte monocytes that are rolling all over the vascular wall can adhere more easily to this to the wall, penetrate. And when they penetrate the endothelium, they deposit into the media and they get a more chronic inflammation disease. Now, this happens either in venous disease as in arterial disease. But this starts in the microcirculation. So we don't see this when this starts. It happens years before we start to see this kind of images. So again, those changes is not very early going. So getting into the topic, what's the data? The Germans started all of this, and they had a very interesting study. Many of these trials on their own are very interesting. You can spend several minutes trying to dissect each one of them because they have their issues, and most of them are database analysis. So it's not all of them prospective long-term evaluation specifically looking for this. It's like, okay, we have this information from all of these patients. Let's see what we can find. And the Germans found that patients with a higher CYP classification were at higher risk of developing cardiovascular disease and a 10-year risk, but also found an all-cause mortality increase in patients with chronic venous insufficiency, that is, higher CYP classifications. Then in Australia, they also found that we have patients with mild chronic venous disease and severe chronic venous disease, and they had also found that patients with severe chronic venous disease had more major adverse cardiovascular events, or MACE, with a hazard ratio of 2.37. Then came the Taiwan, and Taiwan said, okay, let's see all the patients with varicose veins. Again, this is data banks evaluation, and they include everybody that had varicose veins with the code 183, and you can put the 0.1, 0.5, or 9, depending on the severity. And they found that those patients with varicose veins had a higher risk of developing atrial fibrillation. And then came the Chinese. They became a bit more creative, and they had this evaluation of the genetic information of patients. So they said patients with these genetic risk factors for developing cardiovascular disease, and you have these patients with genetic risk factors for developing chronic venous insufficiency, and see what happens. And they found that there was a higher risk in those patients with genetic risks to develop, again, atrial fibrillation. But they didn't find any relations with heart failure. Then the Koreans said, okay, hold my beer. I'm going to analyze 390,000 patients to see if they have varicose veins, what happened to them. And they found that these patients have, again, higher risk of developing heart failure. So all of this data starting to accumulate, and Ms. Onida and Professor Davis sent a very interesting letter to the Lancet and said, guys, there might be something here. There's something fishy going on. And there was this meta-analysis that showed all of the information that I just mentioned, that again, there is interesting stuff out there that makes interesting to take a look of this. Now, what about venoactive medication? Is there a role to play here? Now, again, the idea is to have all this endothelium that is damaged, trying to restore it at least to a more functional, or reduce the risk of being injured. Now, we know that several venoactive medications have different properties, and as the years have come by, newer or more selective information regarding inflammation control, reducing cytokines liberation, and what's so on. So all of them can have an improvement or a benefit for these patients. But I'm going to focus on this one, sulodexide, because sulodexide is the one that has, for many years, been developing or saying its mode of action actually is the integrity of the endothelium, preventing endothelial dysfunction. Now, a few years back, I don't know if you remember, there was this thing called COVID, and endothelial dysfunction was a big thing, and there was a lot of research. And sulodexide has a lot of research in live patients, in clinical applications. And actually, they had this Tunisian study that found that it was proven in a clinical setting, chest pains and palpitations were reduced in patients with COVID. We also, our group, got into the mix, and we found that specifically for endothelial dysfunction, the biomarkers were improved when we used sulodexide. So And they just published this review about all the studies that they had. They have information regarding side effects or not side effects, complications of these patients regarding cardiovascular disease. Although this study is not specific for chronic venous disease treatment, but all treatment that Zolodexide was there, and they had an improved in mortality with an R ratio of 0.63. So, in conclusion, there's a correlation in physiopathology. Causality and causation is still tricky. More severe stages may warrant to a cardiovascular evaluation. Venoactive use can be helpful in some patients, but again, more research is needed for this. And it's difficult to determine if these patients, her varicose veins, are really the cause of her cardiovascular risk. So thank you, and I will stop sharing and appreciate your comments and try to answer any question you may have.
Alejandro, thank you very much for a very interesting presentation. It's a little bit controversial to link the venous and the arterial sort of risks, but this is a very well-established link. So I'm going to invite our guest discussants to just give their reflections on what they've heard, and maybe also just commenting on what do they think this means for day-to-day clinical practice for venous specialists. So perhaps if Dr. Ochoa is there first, and then we can maybe move on to Dr. Patel. So Dr. Ochoa, are you there? No, so maybe Malay Patel. So maybe if you could just give us your thoughts on what you've heard.
Well, thanks, Alejandro, for that. What shall I say? I think controversial is a stronger word. So I'd like to say that there's probably evidence gathering out there to show that venous disease leads to chronic inflammation, and chronic inflammation leads to other problems, especially related to the cardiovascular system, and that includes the heart. Now, the correlation appears to be strong. For many years, many phlebologists or most phlebologists, you would say, you get asked this question by our patients that whether varicose veins would create problems with their heart because the venous return is not enough, and so on and so forth, because patients have a layperson's question. And when we used to say that, well, there's not much evidence seen, we now have quite a bit of analysis done on this to show that chronic inflammation leads to an arterial inflammation on the arterial side, and that includes the coronaries, and maybe includes almost everything. Could be even give you, tomorrow we will see some enhanced study showing that there's a correlation with pancreatitis. I mean, I'm just saying that if there's inflammation. So this is a good topic to work upon, and I'm sure that in the near future we are going to see many more people trying getting to link this and also treating chronic inflammation. My other question is, Alejandro, is did any of these studies show that advanced chronic venous disease or chronic venous insufficiency, the higher SAPE classifications, led to lesser mobility or increased in their immobility, and that probably gave rise to other risk factors leading to chronic heart disease? So, in your studies, did you find any of this correlation, or was it just chronic inflammation?
Yeah, no, it is unfortunately a bit tricky to give you an answer to that. The studies don't focus on that. Like I mentioned, most of them are like database reviews. So they're not very into the specific of patients regarding other risk factors, like you said, mobility. But unfortunately, this is like the chicken and the egg effect, because of course some of the cardiovascular complications complicate chronic venous disease and so on, because you may have a patient with heart disease that his mobility is going to be limited, and he's going to be having very swollen legs because he cannot breathe well. So it, it is again controversial, but this study did not expand more other than the information that I just gave.
So I'm going to invite Liza Ochoa to offer some thoughts and comments. I'm sorry we lost you for a moment there, Lisa, but please tell us what your thoughts are on this interesting link between venous disease and overall cardiovascular risk.
Well, thank you for the invitation, and sorry for this absence. My internet is failing. But well, I think that like in the already comment, the inflammation is the principal actor here, and we need to as Dr. Malay Patel said, that in the future maybe we'll have another information and maybe treatments. We have to educate the medicals that has the first contact with the patients, because we need to that they understand that the cardiovascular risks are not only for the artery disease, no? So it's too related, like we already seen, and maybe in the future it's linked this treatment with proteins, because there's studies that have seen that and demonstrated that these cardiovascular risks like obesity, smoking, and lipoproteins, low density lipoproteins are really linked with this increasing cardiovascular disease and the thromboembolic events. So these proteins, maybe there's a future, and we can, or the investigators can create a substance, a protein or antiprotein or a receptor that we can get there and cut the risk, right, to develop vascular venous disease and thromboembolic problems. And I think that one thing leads to another, that the immobility that the patient has because of the heart failure, it's leading to the edema and progressing the venous disease. And the same thing, that the venous disease in states, higher states like CF6, decreases the quality of life of the patient, and it takes to the patient to be to have lesser mobility. And so that there's a circle that we have to cut in some point. And well, I think that the first step that we have to take, it's to communicate to the general physicians and the other specialties and subspecialties to take care these risk factors and give them the real importance that they have to improve the quality of life, right?
I mean, lots of really interesting comments there. And so I suppose that Alejandro, the question for you and also our other discussants is this. I'm in a clinic at the moment. I have maybe seen 10 patients with chronic venous disease. The data you've shown are very convincing in enormous studies. And I've seen another data, which is that the cardiovascular risk, event risk, is doubled in the next 10 years if you have chronic venous disease. And so should we be identifying and treating cardiovascular risk factors in our venous patients as well, looking at their blood pressure, their cholesterol. What do you think this means in daily practice for us?
Well, again, it is too early to jump into any conclusion because we don't have any prospective trials, and it's going to be difficult to get them. But the thing that basic thing that we can get from this is, like Lisa said, in the first contact physicians, in Mexico, we're not very used to having a regular checkup, for example. And for example, if a physician sees a patient, 40-year-old, 50-year-old, and because he sees him with varicose veins, and he has a very probably advanced stage with skin changes and what's on, you can ask him, hey, have you done your heart checkup? How's your blood pressure? Have you had a recent EKG or something like that? Because that's what I think we can start on. Reinforce if we know, you have a high blood pressure, you're diabetic, you have to really stick on controlling this. Don't deviate more of your medications. Try to reinforce the proper control of his already known risk factors, because he will be at a higher risk, at least with the data that we have. So these little things is what we have to start with. Adding other medication, because if a patient has with varicose veins and given statins or whatever, that's different. But at least let him know that, okay, do a quick checkup and see if there's anything wrong there.
Yeah. So we've got a couple of questions coming in. So we're running short of time, so we're going to be quite quick on this. So Ajay Khanna has asked, does a SEEP grade severity correlate with cardiovascular risk and any particular type of heart disease? So Alejandro, what are your thoughts on this?
Apparently, yes. The apparent heart disease is more, again, with the data, is atrial fibrillation and heart failure. Heart failure, iffy, but that's the more correlation.
Yep, I agree, and I think there are some data that show C4, 5, 6, and C4, 5, and 6 disease has a higher incidence of cardiovascular events. Now, this may be complicated because these patients are obviously older with more obesity and other risk factors. So that correlation causation is difficult, but I think that is true. And we have another question here from Madhuri Gore. Does treatment of chronic venous disease decrease the severity of the cardiovascular problem? This is $1 million question. What do you think, Alejandro?
Again, we don't have the data to have any definite conclusion to that. Again, the sulodexide trial kind of leans into that, but again, it is not a confirmatory, and you will think that it would help to reduce the risk because it will protect the endothelium that actually that's the fountain of youth that we all still trying to find, trying to keep the endothelium whole and functioning well. So it may and it could, but again, there's a lot of gray area to define this, and definitely more studies should be done to this.
Yeah.
And
one of the really big challenges is that you need studies over 10, 15, or 20 years to really understand the benefits. And look, the common driver here is inflammation, we think. That's what we think is the main driver. And so that's the challenge. And in theory, treat the venous disease, reduce inflammation, that may have a benefit, but I will be retired by the time we see the results of these studies. So maybe go ahead.
And sorry, and then you get into another kind of worms, because what kind of treatment of chronic venous disease are we talking about? Are we talking about saphenous vein ablation only? Because that doesn't treat the whole chronic venous disease. Are we talking venoactive medication? Are we talking stockings? So again, there's a lot of stuff that we need to evaluate.
Yeah. Maybe a couple of final comments from our discussants. So to Dr. Ochoa first, maybe. So what do you think we need to do next? Just in a brief comment, and then I'll come to Dr. Patel before we close. So Lisa.
Well, first of all, the education, like I said, and as some studies mentioned, the venoactives contributes to diminish the oxidation of the low density lipoproteins. So there's a path right there, and we could think and hope that it's really promising. And so that's the question, no? Like you said, the million question. And I think that evaluate each patient with their risk factors and improve their treatment if they already have instead the arterial or cardiovascular treatment, or if we can help and contribute to make the complete treatment, because there's a lot of patients that are diabetics and with a lot of risk factors that are undertreated. So let's see the patient's legs. Let's ask them their risk factors and and try to take the whole comorbidities to treat the best way to the patients.
Great. And final quick comment, Malay, just to
Yes, I think the bottom line is inflammation and inflammaging. So your body ages due to inflammation is a very raging topic. And treat venous disease, look at the markers of inflammation, and if they are going down, you should be happy. And I think that's the take-home message for all of us. Professor Ajay Khanna asked a question, and I think 3 years ago, I heard a talk of his in which he had also pointed in this direction that decreasing any sort of inflammation, treating venous insufficiency would, improve the markers of inflammation. So that's the bottom line, I think.
Fantastic. So guys, we are up to 30 minutes. I'm very sorry to Dr. Greenwich. I know you put out a question about the Martell ulcer. We're not going to have time to go into that. That's a whole new topic, I think. But I really want to thank Alejandro for a fantastic, thought-provoking presentation, and our guest discussants. So this is part of the VLU, Venous Lymphatic University education program. And really just a reminder that next week we have this fantastic session, which is going to be talking about direct radiofrequency ablation. So thank you very much. Goodbye to everybody. And I wish you all the best for the rest of your day. Thank you.
Thank you very much.
Bye. Thank you.
Thank you.